this is to end in fire, then we shall all burn together. Watch the flames climb high into the night, calling out, Father, oh, stand by and we will watch the flames burn over and on the mountainside. And if we should die tonight, we should all die together. Raise a glass of wine for the last time, calling out, Father, oh, prepare as we will watch the flames burn over and on the mountainside. Desolation comes upon the sky. Now I see fire inside the mountain. I see fire burning the trees. And I see fire hollow souls. I see fire blood in the breeze. And I hope that you remember me. Surely I'll do the same. Come finding mountain holes. We got too close to the flame. Calling out, Father, oh, hold fast and we will watch the flames burn over and on the mountainside. Desolation comes upon the sky. Now I see fire inside the mountain. I see fire.
Hey guys, welcome to our next webinar. We're very fortunate. We've got Dr. William Ha here with us, really going to be capturing everything to do with endodontics today. What you need to know, what's out there, what are we doing that's right, what could we be doing that's better, what could we be doing that's more efficient use of our time and to get, really the best results, get people out of pain, having root canals that are stable, that you know are going to last and that we can treat restoratively afterwards as well. We're very fortunate. Dr. William, he's going through his DClinDent in Adelaide at the moment. He's got a wealth of experience in general practice prior. He's an app developer. He's also looking at supply chains and helping endodontists and people interested in endo get kind of specialized equipment into Australia and helping supply that. He's got some cool clamps out there as well. So he's a man who's in every aspect of dentistry, in education, in practice, in research, and he does a lot of research. And if you haven't checked out already, he's got a really fantastic Instagram and Facebook page where he's going to summarize and go through a lot of what we're going to go through today. But hopefully today is going to be more directed towards younger clinicians, figuring out what exactly are we doing that, like I was saying, that's going to be the best use of our time and maybe rethinking how we are doing our root canals and what we can do that's better. Once again, we're really fortunate to be sponsored by Mordent. They're an awesome company, lots of support. We've got Dr. Harry Schlan here, going to talk to us a little bit about M-guides and digital, and how digital practice can fit into planning surgeries and doing a lot of things. There's cool stuff these days. We're just talking with Dr. William how, some root canals these days where you've got, canal obliteration, difficult accesses, you want to make sure that you are preserving as much tooth structure, that even those can be done digitally guided as well. So everything is fitting in, and we're going kind of stepping forward into the digital realm more and more. So without further ado, we'll get straight into it. Thanking Dr. William Ha and his presentation today.
Yeah, thanks. You're going Harry first, right? Or me first?
No, straight into you.
Okay, me. Okay, all right. So I go share screen. All right. And yep. Yeah. Okay. Yeah. Hi, everyone. So thanks, Alex and Dan, for inviting me to talk. This presentation is something I've been meaning to do for quite a while, because I think there's a lot of courses on machines and materials, on gadgets, but not often on specifically what works and the evidence behind it. So my background is that I did my dental degree in 2007. I did my PhD in endodontic biomaterials in 2017, and now I'm in second year postgrad endo. But you'll also notice I've done a lot of other things too. So my declarations are that I do bring stuff into Australia, endodontic stuff, but I also make phone applications. Some of them are relevant to you, and particularly so in this presentation. Now, a practical point, which I think it's worth knowing for self-directed learning, is that you should try to focus on studies that have outcomes that are important to your patients. Patients want to be comfortable, they want to keep their teeth, and they don't want you to stuff up the case. You'll find papers that often disagree with each other, and if that's the case, look for a systematic review. They often compare all the studies, and hopefully what's right should be pretty obvious. Something else that's good to look at is surveys. And they're good if you look at what the endodontists are doing. You could apply this to any field. And it's good because you can look at a baseline of what the specialists are doing. And it keeps you up to date as to what everyone is doing, and an idea as to how to judge things. But lastly, don't get sucked into buying gear that isn't proven. If your local specialists aren't using it, if they're not doing it, it's probably not worth buying into. You don't want to be a clinician who has like all the gear and no idea. So many of you are at different stages of your career. So I know there are students, there are new grads, there are experienced practitioners, and I think it's wrong to assume you all have the same skill set. And I think it's also wrong to assume none of you should ever do molar root canals. Although it is true that more stuff-ups will occur as you move from anteriors to posteriors, there's more to stuff-ups than just the position of the tooth in the arch. There's points such as canal calcification, canal angulation, and canal curvature. So if you were to challenge yourself with a case that's slightly above your ability, that's fun. Like, it helps improve your skills, gets your heart racing a little bit, and makes you think a little bit more. But if you try a case that's completely beyond your ability, you're going to be in trouble. So a simple way to advance your endodontic skills is to use some sort of difficulty criteria that objectively scores cases. Now, I was involved in this app, which is completely free. You can download it. If you don't like it, just uninstall it. You don't have to pay anything. And it includes 2 criteria: the full original version, which you may have learnt in undergrad, which is the 19 questions to consider when you start a case. The other is an abridged version, which is 8 questions, which is a bit more technically focused, such as the canal curvature. And if you don't like the full version, just use the abridged version. But whatever you use, if you're someone who's just graduated, I think it's wise to start off with lower score cases and keep a record of the cases and the scores that you do. Now, you can slowly work your way up to the mid-range scores as you become more experienced. It's not wise to jump into a high difficulty case if you've only ever performed easy cases. A mild challenge is fun, and an impossible case means you can get into trouble, and it can cost you far more than just your time. Now, when we see a patient, we have multiple tests we can do. It's very easy to go into autopilot because most of the time we're right. It's usually pretty obvious, and you certainly don't need to do every test under the sun for every single case. But the key point I want to make on this slide is that no test is 100% accurate. Don't rely on a single test for your diagnosis because you should at least be doing most of the above. There's no single test that is always right in every case. So let's put that table into practice. If you saw a patient who describes soreness and points at their 1/6, there's large restorations along the whole arch, and there's no obvious caries. There's tenderness to percussion on the 1/6, and there's PDL widening, but no periapical radiolucency. Do you think there is pulp necrosis? Now, from the information above, if the 1/6 was truly necrotic, then there's signs and symptoms that they do make sense. However, there isn't actually a test that's been performed to rule out the tooth is not vital. So without doing a cold or electric pulp test, you could be performing endodontic treatment on teeth that are not healthy. So in this scenario, the pain could be from muscle pain or sinus pain. It could also be a cracked tooth. So endodontics may not be necessary. Now, with periapical radiolucencies, you have to be very careful. Like, widened PDL doesn't necessarily mean that tooth is necrotic. It could be that it's, say, been slightly traumatized. It could just be something how you perceive the radiograph. If you go back to the table, it's definitely not. It's nowhere near 100%. Periapicals are actually, like, they're very good, but they are definitely not your end all and be all of diagnosis. So here's another scenario. So let's say that 2-1, it has a periapical radiolucency, and it's not responding to cold tests, and it's not responding to electric pulp tests. Do you think there's pulp necrosis? Now, if you go back to the table, you'd say that, well, these three tests are probably three of the more accurate tests. So it would seem fair to assume the pulp is necrotic. However, history is one of the best ways to confirm necrosis, and percussion is a very easy test to do. So there's no history of pain, no caries, nor deep fillings. So these are red flags that the pulp may not be necrotic. Something that's also worth keeping an eye at, although not in this picture, is pulp canal obliteration. So let's say you have a patient coming in with dull pain and they can't localize the source, and you started doing some pulp tests. If you come across a tooth that is not responsive, it may not be the cause. Yes, the canal may be obliterated, but that doesn't mean that that specific tooth is the cause. So always do more than just considering how your pulp tests go. So rubber dam, it's pretty simple. You get more success with rubber dam than without it. The percentage may be a token increase in success, but there's many reasons to use rubber dam. There's actually an article called 57 Reasons to Use Rubber Dam. Like, some of the reasons are strong, some of them are weak, but there's definitely a lot of reasons to use rubber dam. Now, the one that we like to focus on is that in endodontics, you're trying to keep bacteria out. You're trying to also get better bonding and seal of your restorative materials, which you'll get with rubber dam. But you'll also not get irrigant down your patient's throat, and you won't end your career by getting a file stuck in their lungs or their intestines. And rubber dam literally costs 50 cents for a single rubber dam. So if anything, just think of that 50 cents as a insurance against your career. It's pretty cheap for something that can save your career. And And as a side note, you might notice that there's been 2 ingestion cases here. So just keep in mind that you should floss both sides of your rubber dam, so if it does break, you can catch it. But yeah, there's no reason to do endodontics without rubber dam, and it's pretty indefensible if something happened. So I've divided my presentation into 4 parts, and I'll have a little summary for each day just to make sure that the message gets taken home very well. So for the first part, you should base your diagnosis on the history, the pulp responses, and the radiographs, and try not to skip anything. And always use rubber dam. It does improve your outcomes, and it can save your career. Now, if you follow different endodontists on the internet, they'll often argue about the size of the ideal access cavity preparation, and it's basically an argument of whether you want total straight line access versus a preparation that aims to preserve dentine. Now, the key differences are that if you prepare wider, you'll see more, you'll find more, and you'll clean out more. So that's traditional on the left. However, by doing so, you could remove far more dentine, which makes the core area of the tooth hollowed out and vulnerable to fracture. And if you were to do a crown prep on the tooth on the left, you can imagine that you've practically decoronated the tooth. Now, if you make something too small, it may be very hard to get your instruments in there properly. It may be very hard to find things and see things, of course. So the ideal preparation, realistically, is anything that does not predispose this tooth to failure, whichever way that may be. So you may have to ask yourself for each case, what is the more likely reason for this tooth to fail? If you think it's going to fracture, then maybe you should focus on methods to minimize the chances of it fracturing. If you think that infection is an issue, then maybe that should be cleaning the tooth out as much as you can should be the focus. So yeah, depending on what you read, the cause of endodontic failure, it could be endo, it could be pros, or it could be perio. It is overgeneralizing to treat every tooth as if it will fracture, or treat every tooth as if it should be gutted out, prepared to very wide shapes for disinfection, because it's overgeneralizing. An example would be not every patient has periodontitis. You shouldn't treat every single patient as if they have periodontitis. And you'll see here that many of these endodontic treated teeth are removed because of perio. Doesn't mean we should refer every single patient to a periodontist. So yeah, again, it's a question worth asking yourself before you start a case. If this case is going to fail in the future, what do you think is the likely cause? And then try to treat based on that. Now, a commonly asked question is, what apical size should I prepare to? Now, unfortunately, out of the best studies, there's generally no difference between the larger sizes and the smaller sizes. So there's one study that showed that if you prepare a few sizes larger than the first apical binding file, the lesions heal faster. And note that they had a minimum apical size of 30. It doesn't mean that 30 is the magic number, but you can see that many of the studies will hover around this number as their minimum. I'm not saying that 30 is what you need to aim for, but it's as a trend, that seems to be where many of the studies have hovered around. But every tooth is different. That's a note in what I was going to say for this, but every tooth is different. You've got different anatomy on different teeth, not just the tooth itself in the arch, but say if you've got something like resorption with age, it all changes. So, and also when it comes to irrigation and obturation, there's different things that make things more or less convenient. So end of the day, unfortunately, it is whatever seems to work well in your hand with the equipment that you've got. But unfortunately, there's no way anyone can just tell you arbitrarily to prepare to a specific size. Now with working length, if you don't use an apex locator, please use one. It's almost always more reliable than just using x-rays. Now if you solely relied on radiographs, you're guessing the position of the apical foramen, which can often range somewhere between, like, to the tip to say 3 millimeters short of the radiographic apex. So, like, say 3 millimeters is a significant difference between, say, extruding a lot or being very short of the apex. Alternatively, and if you use an apex locator, out of all the brands, you'll find that if you were to use one and aim for the so-called 0.5 mark on the apex locator, which corresponds with the apical constriction, you'll find that you'll be roughly, say, 95% of the time, you'll be 0.5 of the apical constriction, which then means that it is very rare for you to extrude your instruments, extrude your sealer, and extrude your gutta perca. So if you aim to be at this 0.5 on the apex locator, you should rarely extrude. Now, coronal pre-flaring. So these are rotary files which are often viewed as auxiliary files. So if you buy a pack of rotary files or a set, quite often these aren't included. And it's something that you have to potentially buy separately. Now, you don't need to use them for every case, but it's worth having some available. If you were to place, say, a 10K file towards the apex and it's super tight, it's very hard for you to know whether it's tight because of the canal curvature or because there's some sort of calcification, whether that be apically or coronally. If you were to use the orifice opener first, you'll be able to explore your canal better with your 10K file because you'll have far more space coronally. And it also means that by doing so, you'll be able to get your irrigant further down sooner, which makes it easier to instrument with the 10K file. And as an aside, it also helps your apex locator work better. And yeah, it just makes your life easier. Now, with these two images, it's ProTaper on the left, ProTaper next, and Twisted File Adaptive on the right. Just as two different companies, two different styles. Now, if you were to place the 10K to length, which is the purple line, and it's tight, and then you try to place the 15K file, now the 15K file will be pretty much binding along the whole canal from the coronal to the apical end. Now, if you were to use the orifice openers, being the orange lines, you'll find that if you were then to insert the 15K file, it would only be binding in the apical half, if at all. So it pretty much halves the amount of work your next instrument will have to do. Now, as an aside, if your 10K file cannot get to length, don't immediately try to use the orifice opener. The orifice opener should only be used to a point that's roughly 7 millimeters short of where the 10K file can reach, or the first curvature of the tooth, whichever one comes first. The 7 millimeter rule is, as per this graph, you can see that the tip of the orange lines sits within the path created by the 10K file. If you insert the orifice opener deeper than the 7 millimeter mark, that means that the tip is significantly binding and it can break. So here are the two orifice openers that I was mentioning that are available on the market. There are many others. These are just ones I've used in the past, and they are shorter than your average rotary file. So they have like a working length of like 17 millimeters or something like that. And this is good particularly for posterior teeth because it means that if you use these first, you can get these in there quite easily. And then you can get your longer rotary files into the tooth far easier because the orifice is now bigger. Now the picture on the bottom is how to use the 7 millimeter rule in practice. So if your tooth is 21 millimeters in length, you want to get the rubber stopper in a position that corresponds to as if your file was 7 millimeters short. So you just have to imagine in your head the 7 millimeters plus, or 7 millimeters minus the working length, and that gets you the length that the rotary file should go to. I don't know if I said that right, but just focus on the image. It will make sense the more you look at it. I have difficulty explaining it, but I'm a more of a pictures person. Something you may have noticed in the past is that if you insert a 10K file to length and it was fine, you may find it quite hard sometimes to get the 10K file, 15K file to length. Now, this is because the transition from the 10K file to the 15K file is geometrically the largest percentage jump in file radius, which also explains why, say, the 6, 8, and 10 feel quite flexible, while the 15 feels quite rigid. Now, if you use a rigid file, this means you're more likely to transport the canal. And transportation isn't good. So on your left, you can see there is different severities of transportation. The more you transport, the less likely any of your files are going to be cleaning the canal. You may see a lot of dentine coming out, but if you're not following the original path of the canal, then it's pointless dentine that you're removing. You're just still missing the canal. So it's worth looking into if you don't have already some rotary NiTi glide path files. You don't need to use them for every case, but I'll explain why they're good. But as an aside, I can imagine most of you are using rotary files, but I do know that rotary files are not taught at some universities. And if you haven't been taught, you really should get taught. If you should go meet someone to teach you, whether it be a rep or some endodontists at a course. Just get someone to teach you. If you don't use rotary files, you'll have at least 20% more cases not heal. So that's 1 in 5 cases that don't heal if you've been staying with only hand files. And also, there's 2 types of rotary files in general. Like there's many types, but just to keep it simple, there's 2 main types. So you have the non-heat treated files, which tend to be silver in appearance as a rule of thumb. If it looks like it's silver, it's probably not heat treated. And if you push on them, they tend to bounce back into a straight position. So if you're going in a straight canal, these are great. They're strong, they cut quickly, and they're useful for removing gutta perca. However, if you're entering a curved canal, these very rigid straight files will tend to transport the canal. So you should consider what's known as a heat-treated file. And these tend to be colored. So as a rule of thumb, if it's not silver, it's probably heat-treated. So these are flexible files, and they also, you can pre-curve them. So if you get one of these heat-treated files, you might have one lying around, you can literally just pre-bend it. Actually, I don't know if you can actually see it because of the, whatever. You can use your imagination. You should be able to, there you go, should be able to pre-bend it. You can see there's a curvature on it. And as it goes in the canal, it won't straighten the canal or transport the canal as much as if you were to use a non-heat treated rotary file. And also, if you pre-bend it, the other advantage is if you're having difficulty getting access into the tooth, by having the rotary file pre-bent, you can sort of curve it in into the canal, and then you turn on the rotary handpiece, and then it gets into the canal. As opposed to something that's straight, you really have to get the patient to open wide. Whatever files you use, fractured files are a reality, and it's not a matter of if, it's a matter of when. So, but if you know what you're doing, it should rarely happen. If you're going to break a file, it will be almost always in the apical third, and it's usually 3 millimeter tip. So this is a critical area where you need to be probably the most cautious. So back to this sort of picture again, if your 10K file gets to length and you were to try to insert first shaping file of either of these 2 systems, or any other system, or most other rotary systems, you'll find that it's quite a jump between the 10K file to your first shaping file. Now, the tip of the rotary file of the yellow lines, if you were to try to push that into the canal, you'll find that the tip is obviously working quite hard to get from the top down to the position of the working length. And that's why it breaks, because the tip is being pretty much jammed in there trying to get to length. Now, if you were to use a glide path file, you can see that, let's say on the left, the Pro Glider, it's pretty much an intermediate sized rotary file. So that way your first shaping file has less work to do along the length of the file to get to length. Like that pretty much has to cut half as much dentine to get to length. And hence it'll be less likely to break at the tip. Now, the one on the right from Cabo Kerr, the Traverse, it's a little bit of a different concept, because the idea is that once you've used the Traverse, if you then move on to the SM1, or the size 20, it's only the last 3 millimeters that's cutting, and everything else is being untouched. And alternatively, when you go from the blue to the dotted or the dashed glide path file, you can see that the tip itself isn't doing as much work, because the shape or the size is very similar to the purple. So just keep in mind that if you use something that's like most glide path files, they usually fall between the sizes of somewhere between 10 and 20, really, because that's usually the hardest part. That's usually the stage where you tend to transport the canal. And if you use a glide path file, you'll generally find that you'll have, things will just flow a whole lot smoother. So yeah, so whatever you use, I'll just go back to the picture. Whatever you use, if you find that after you insert the 10K file, that if things are feeling pretty tight, it is worth looking into getting glide path file before you try to ram in the first shaping file. So if the 10K file can get to length, then consider using. If the 10K file it can get to length, but it's a little bit tough. Try considering using a glide path file as your next file. Obviously, if you can't even get the 10K file down there, I'd be very cautious about using a glide path file all the way to length, because if the 10K can't get down, the glide path can struggle too. But almost all companies have glide path files, so just be aware and look into them. So the mini summary for the second part is to use an apex locator. The jury is still out there when it comes to access, shape, and prep size, but I think you should be just practical and pragmatic. Well, what do you think what do you think would help the case last longer? Do you think it's going to fracture, or do you think so the endodontic disease is going to be hard to eliminate? Nickel titanium should be a part of your practice. You should have at least a heat-treated NiTi system in your practice if you're going to be doing, say, posteriors, which have curves. Consider pre-flaring the canal if the canal is tight coronally, and then consider a glide path file if the canal is tight apically. And yeah, it's always worth knowing that realistically, if your rotary file is going to break, it is going to be in the apical third, and it's usually the 3 millimeter tip of the file. So this is a slide that's quite dear to me. Basically, don't use EDTA gel or EDTA paste. And literally, if you look up any studies that compare EDTA gel against EDTA liquid, you'll almost always find that EDTA gel, it just makes things worse. So what the gel does is makes your instruments feel oily, which makes you think and feel that, well, maybe the instrument's well lubricated, but in reality, the gel sticks the dentine debris onto the file, which reduces the cutting efficiency, it reduces the cleaning efficiency. And because it's not, say, water-based, your apex locator, it's like oil-based, it actually blocks the transmission of your apex locator. So yeah, there's really no reason to use EDTA gels, and you also increase the risk of file fracture. So I find there's absolutely no reason to use EDTA gels or pastes, particularly if I can already flood the access cavity with either EDTA or hypochlorite, which you really should be able to do anyway. Like if you've got an access cavity preparation, which you obviously do, you can fill up the whole chamber with EDTA or hypochlorite, and every time you withdraw the rotary file, you'll actually see the debris sort of shaking off the rotary file if the access is flooded with irrigant. So in moderately curved canals, you have somewhere between 2 to 4 times more risk of file fracture if you were to use EDTA gel. If your file fractures, you won't be able to instrument always to the apex. Like even if I said before that most of the time the file fractures in the apical third, that doesn't mean it breaks literally at 0.0. You could be having a file breaking at like 3 millimeters short of the apex. And that would then mean if your file broke and you're 3 millimeters short of the apex, you have 3 millimeters of uninstrumented canal, which is probably the problem area, the area full of biofilm, which is causing apical periodontitis. So if you have RC prep, throw it away. I literally can't find any, I can't even think of a joking use to use it for something else. RC prep or any other gels, they're all pretty useless. Now, despite how many irrigant choices that are available on the market, you'll see that practically all endodontists in the US and in India, they'll use hypochlorite, sodium hypochlorite. And the idea is they try to maximize the time that hypochlorite is in the canals, because the goal of endodontics is to remove and break down bacteria in their products, which cause apical periodontitis. And we know that hypochlorite, sodium hypochlorite, is actually best at this. So the American endodontists, they prefer concentrations greater than 5%, while the Indian endodontists prefer concentrations above 2.6%. So this is a fair guide as to what you should be using in your practice when you do root canals. Like something, I'm not saying you need to use like 5%. I'm not saying you have to use 2.6%. Like if you're within that range, at least you're following what most people do. And yeah, again, the goal again is to remove biofilm and kill bacteria. So you want something that basically you want something that kills. Now, and this is a very busy slide, and it's telling you a lot. So I suggest that I'll give my PowerPoint to Dan and Alex. And you can take your time looking at the slide. You can even look up the original article if you'd like. But I think it's one of the few studies that tried to investigate all the factors. So rather than me showing you 10 different papers on this sort of topic, this paper seems to just look at the good overview of like multiple factors. So if you look at the column which says the mean, that shows how well irrigant penetrates to the apex. And the higher the percentage, basically the more the irrigant has reached towards the apex. If you use a smaller needle, it penetrates better. If you were to place your needle closer to the apex as opposed to halfway down towards the apex, it will penetrate better. Now, and if you create a larger apical taper, the irrigant will also penetrate better. And if you use more irrigant, it will penetrate better. So there's a pretty much fundamental concept for irrigation. It's not just really just stick any needle tip in there and squirt away. There's a few little factors to consider when it comes to irrigating towards the apex. Just imagine you're trying to clean one of your cups. You need to get your brush there. You need to get the detergent there. You need to get the water there. If you're just really washing your cups and only just the tip, then it's not going to be clean. Like if you wouldn't do that on your own dishes at home, then why would you do that on a tooth? Like it's just endodontics. I'd say endodontics is fundamentally quite simple in many of its concepts. If you clean anything at home, you should know how to do endodontics. Okay, now you've probably had people try to sell you different devices to help you stir your irrigant in the canal. And the most popular ones are these three, being the Eddy, the Endo activator, and the ultrasonic assisted methods. Also, in this example here is the IriSafe from, I think, Acteon. Now, there are studies that compare all these things against each other, against your just plain irrigation with your syringe. And whichever company is trying to sell you one of these devices, they'll always cherry pick whichever study that makes their product sound better than the others. But if you really stack up the studies against each other, all that can be conclusively said is that they're all better than just using a syringe. So as an example, if you look into ultrasonic irrigant activation, there's a meta-analysis that's been done, and the only decent clinical study showed that when it comes to healing of apical periodontitis, there doesn't seem to be a difference against just using normal needle irrigation. So despite all the stuff that they do in the lab, it doesn't seem to change your patient outcomes. Now, it's not saying that you shouldn't use these things. Of all things, it seems to probably help, and at least purely from a lab point of view, it helps. But my point would be that don't worry about buying fancy tools if you aren't actually using your irrigant needle properly. So if you're irrigating properly, there's a chance that these fancy devices may help a little bit. They may not even help at all. But the evidence is always based against someone who's irrigating properly. If you're doing half-assed irrigation, then you can expect a half-assed result. Now, again, so the tools I showed you before, that they aim to just stir the irrigant. So if your irrigant hasn't reached the apex, then all you'll be doing is stirring pus and biofilm upon itself with no irrigant to help dissolve it and get it to go away. So my analogy is when you flush the toilet, if you're cleaning a toilet with a toilet brush, you flush before you use the toilet brush, I hope. You don't use the toilet brush before you're flushed, because otherwise there's shit everywhere, and all you're doing is smearing it everywhere, and it's not any cleaner. It's everywhere. I hope that makes sense. I wish I had little screens so I could see your responses, because I think that's a bit funny. But anyway, okay. So another thing that it almost seems rarely spoken about at courses is actually how to prevent hypochlorite extrusion. So this is one of the reasons that lead to people using either weaker percentage of hypochlorite or even not even using sodium hypochlorite, which is a bit sad. You do endodontics because you want it to work, and you shouldn't resort to stuff that doesn't work as well. So there's a Greek fellow, Batsiokis. He compiled all the case reports on extrusion and found there are some trends as to when extrusion occurs. So these are in upper teeth with periapical lesions. This is probably because they have less bone around the apex of the tooth. And if there's less bone, that would minimize extrusion into the tissues. Hang on. Yeah, hang on. If there's bone, that would minimize extrusion into the tissues. And if there isn't, then you're more likely to extrude. Now, extrusion cases tend to occur more often if you use an open-ended needle. And also, if you tend to use needles that range from gauge 23 to 28, it tends to have more extrusion. So if you imagine, as an exaggeration, you were to use an etch tip versus a local anesthetic and try to squeeze out etch, and how quick that comes out, versus if you were to use, say, a local anesthetic tip and see how much liquid comes out. It only takes a second for you to empty the full syringe of etch. Well, it takes minutes for you to empty all the liquid from a local anesthetic needle. So if you were to extrude, if you were to use a fine needle tip, if the patient felt pain, you would stop immediately, and then there wouldn't be that much more extrusion. If you were to use something like an etch tip, by the time the patient feels pain and has responded, and then you've had time to react, you've had a whole lot more liquid go past the apex. So if you are going to extrude, it's going to be more of a disaster if you have a larger needle tip. Yeah. If that doesn't make sense to you, please message me, because I think it's obvious, but for whatever reason, a lot of people don't seem to know that. So, but I don't know whether it's because it's just not explained or not taught, but please, if you don't understand, please let me know, and I can forward you to any of the papers on scientific papers on extrusion, how to prevent them, and they almost all say the same thing. So when it comes to prevention, take care in high-risk cases. If you have a maxillary teeth with periapical lesions, or if there's a perforation, or you know the tooth's been over-instrumented, you know that they're high risk, so you may want to just be a little bit more aware and be more alert. You should use a side venting needle, so that means the irrigant goes. This is my needle tip. I had a syringe. This is, you do too much endo if you have stuff at home like this. If rather than my irrigant going this way, it literally goes, it sprays out a little bit to the side. So that means you're less likely to extrude. Now, having said that, it's not going to save you if you're past the apex or you're using a super large gauge. Now, the reason why you're recommended to use a lower lock irrigation needle, which I'm sure most of you, if not all of you, do, is if you have a lower lock, it should be obvious, you tie it on, and the needle itself cannot fall away from the syringe. Some people use the needle type, which just plug in like that with pressure, which means if you're pushing too hard, the whole needle flies off, and the residual irrigant can then spray in the patient's face. So that's not really extrusion per se, it's not past the apex, but if you get it in their eye, I'd say that's probably just as bad, if not worse. Avoid wedging the needle in the root canal. So when you're irrigating, it's boring as hell, but you should just keep on doing this with your hand. Now, it serves two purposes as you're irrigating. So it goes in the tooth. If plastic tooth here, which again, I just so happen to already have. If you just keep on just going up and down as you irrigate to go to length, and you slowly withdraw and just keep doing that over and over again, that means that you will always know that the needle hasn't bound. And as a side note, if you measure your tooth in advance, obviously not out of the mouth, but on the X-ray, you can actually pre-bend the needle to that working length. So you're pretty confident that you won't go any deeper than the working length if you've bent your needle at that distance. The needle should never look if it's totally straight, you're in trouble, because you'll extrude and you won't even know. Your needle will go past the apex and you won't even know. And also, if you use a lower diameter needle tip, which is ironically a high gauge, so a 30 gauge is this very small irrigation tip, and that means if you do extrude, you'll extrude so slowly that the patient will respond, and then you'll be able to withdraw the needle out, and then it won't cause as much damage if you did. Okay. So with choice of medicament between Endodontics and leather mix, so bluntly put, there's no reason to use leather mix over Endodontics. Leather mix has less antibacterial activity, and it also stains more. The steroid, based upon what the manufacturers divulge, it's the same percentage. So when it comes to pain relief, it should be the same. I literally can't see any reason to use leather mix over odonto paste. So we're very lucky to have both available in Australia. So you do have a luxury of choice, but I don't see the point of using leather mix. So when it comes to placing calcium hydroxide medicaments down a canal, pretty much the two most popular methods that are worth talking about is using a spiral versus a needle. And you'll find that based on the studies, the lentilized spirals create more, denser, well-packed, less voidy calcium hydroxide filling of the canal. And typically, if you have less spaces, less voids, that means there's less chance of bacteria to grow, and hence more bacteria will be killed. Now, if you use the Navi tip, it does come in gauge 30, which is moderately new when it comes to these studies. And you can see that maybe if you use a 30 gauge, purely by looking at density, it could be equal to or better than the lentulo spiral. But typically, if you use any tips that are smaller than a 30 gauge, you can see that it's usually worse than using a spiral. Now, if you do use a lentulo, the thing to be aware of is they come in different sizes, and they can bind and break in the canal if the canal has not yet been prepared. So it's important to know the sizes of the lentulos in your practice, because they're not always color-coded. So at least for this example, you can see that the red is size 25, but you can get a lot of lentulos which are just basically all just silver. And unless you know exactly what the dental assistant gave you, you don't know the size. Now, if you haven't prepared the canal to matching size, then you're safer off even using a hand file, such as like 10K file. And I specify the 10K file because you don't want to create a ledge. If you want to use this lentulo size 25, then you should at least prepare the canal to a size 25. If you're going to use a lentulo that's size 40, you really should have a canal that's prepared to a size 40. Otherwise, you'll break the file, break the lentulo. And just like hypochlorite extrusion, you can get calcium hydroxide extrusion, which is it's potentially a disaster. Well, and these pictures are a disaster. So it's typically uncommon, as it's usually hard to extrude large quantities past the apex. However, it can happen. And I suspect this is when the calcium hydroxide has dried a little bit at the end of your syringe, and then it's become clogged. And then you push really hard on the needle plunger, and suddenly a lot of calcium hydroxide squirts out. Now, if it's extruded, as it's less soluble than the sodium hypochlorite, what happens is that it tends to travel, and then it starts diffusing and dissolving and creating its toxic effects. So that's why you can see in the lady on the bottom left, it's causing an effect on that side of the face. Now, if you look at the cases in literature, pretty much most of them involve using a needle. So like a syringe delivery system where the calcium hydroxide is injected. And the point is also that when you use a needle, you have far more likelihood of permanent damage, particularly paresthesia. So with you can even just try it for yourself. Like it's probably easy to visualize. If you got a syringe and you squirt it, it just keeps going. As opposed to a lentulo, the most that can happen is it goes sideways. Like if it was me, I'd rather break a spiral filler in a canal and painstakingly either try to remove it or obturate as it is than have a patient who ends up like this in hospital. Because that looks like, if it isn't career ending, well, it probably should be, because that's to me, that's just, it's negligent. Like it's obviously accidental, but it was completely avoidable. So my mini little summary for the third part out of 4 is don't use EDTHLs. And then when it comes to irrigation, use a 30 gauge needle, place it near the apex, and be very gentle. And you can use activation or agitation methods. They seem to help from a lab study point of view. More stuff seems to come out, but they haven't been proven to lead to better success. So you still need to, at least at a minimum, irrigate properly to the apex. Odonto paste is I think it's better than leather mix. I don't really see the point of it if you've got the option. And if you're using calcium hydroxide, it's generally best placed with a lentulo spiral, but the canal needs to be prepared adequately prior to placement. The next is just don't use cotton pellets in your temporary restorations. That's like leaving a wet cloth on your dishes after you've done the dishes. Now, all the studies on cotton pellet show that you get more bacterial growth in the canal. The fibers on the cotton pellet can also sort of stray and be at the margins of your temporary restoration, leading you to have a leaky temporary restoration. So if you squint on the picture on the left, you can see the fibers sort of up the wall, as opposed to if you say Teflon tape or plumber's tape, where there is no stray little fibers. Alternatively, you could just place straight cavet. So don't even worry about a spacer, because at least with ultrasonics these days, if you just place the ultrasonic up against the cavet, the whole thing just flies away. I personally think cotton pellets are a relic of the past, and I don't think they have a place normally in endodontics. And when it comes to obturation length, pretty much consistently the studies show that the obturation should fall within a range of 0 to 1 millimeter from the apex, and there's slightly more failures if you're short, but definitely more failures if you are long. So if you extrude, you tend to have far more failures. And when it comes to methods of obturation, if you were to compare lateral condensation against single cone and carrier-based and warm vertical compaction, you'll typically find, say, the two on the right, being the warm gutta-percha techniques, tend to have less voids. So if you're not too sure what's carrier-based, that's thermofill. And an example of warm vertical compaction is a product called System B. But yeah, like typically you'll find that the warm gutta-percha techniques tend to fill the canals better. But also, if you look at cold lateral condensation and compare it against single cone, there actually seem to be quite comparable between the two, all of the studies that compare them directly. So it's quite interesting. But the point would be that this is lab studies. So quite often in lab studies, they find easy cases. So single canals with minimal complexity. So looking at this, it's very easy to say that, yeah, maybe using some sort of warm gutta-percha method, such as a carrier-based or warm vertical compaction, is always better. But the concern really is that if you did use warm gutta-percha, whatever your technique, just keep in mind that you do have a higher risk of extrusion. So with the lab studies, they're not looking at extrusion. They're just seeing how well the gutta-percha travels laterally. But if you're going to have a failure, it's often related to your extrusion of your obturation. So if you are going to use any of these techniques, being carrier-based or warm vertical compaction, you really need to make sure that you prepare to the apical constriction, but no further. You need that apical constriction to be that little block or barrier to minimize the risk of extrusion. And also you should gauge your apical seat before you obturate. Because if you're just eyeballing it and just going autopilot and preparing to let's say a 2506, but at the apex was slightly open and it was a size 30, you put your gutta-percha in there and it seems nice, but when you melt off to the last 5 millimeters and then you pack down, it'll just pop past the apex. I hope you can visualize that. I should have made a picture on that, but yeah, you need to gauge so your warm vertical obturation doesn't go past. And with if you're going to use thermofill or gutta core, definitely read the instructions for you. So a little bit too much to explain here, but you've got to have perfect technique, otherwise you will extrude or be very short. When it comes to sealer types, the only types of sealers that are known to have failures are fortunately types that aren't available in Australia anyway, being the resin GP chloroform mixers, as well as the methacrylate resin-based sealers. And everything else from a success point of view is either similar or there hasn't been any studies. But success-wise, at this stage, most people will say they're much for muchness, and I wouldn't base like if you do endo, I wouldn't be gloating that you use the most expensive sealer available or the cheapest. I'm not saying use the cheapest, but it's whichever one you use, it should be something that you can comfortably place, is radio opaque, and seems to make sense. That's just don't just arbitrarily go for the most cheapest or the most expensive or the most sort of fear of missing out sealer that's available. Now with sealer puffs, you might have found throughout your training or your experience that you found a lot of people arguing about whether you should aim to have sealer puff or you should never have sealer puff. Now, if you look at these studies, you'll find, if you look at the red, which is extrusion, the one study seemed to prefer it. Most studies fall somewhere between saying that maybe there was possibly no difference. And then there was one study that said that sealer puff was bad. So that's pretty much explains why you'll find people on both sides arguing different sides. But if you look at the sample sizes, they're actually quite small. So realistically, that's another reason why there hasn't really been a decisive study. So this is why a meta-analysis is good. It combines these studies together and tries to find where the weight of the evidence falls. And you'll see that when you combine all the studies, the weight of the evidence says that if you do have sealer puff, that you will have a 32% chance increase of a non-healing outcome. Now, this doesn't mean that your endo will definitely fail because you have a sealer puff. It doesn't mean the tooth will be extracted. It just might mean the tooth may take longer, the periapical radiolucency may take longer to heal. But the point would be that you shouldn't be intentionally aiming to get a sealer puff. Like there's definitely techniques, which I'm not going to tell you how to do, to force yourself to have a sealer puff, but there's no point. It's not going to help. Like, if you'd have methods to try to intentionally avoid sealer puff in every case, and literally you're using minimal sealer in every single case, I think that's also a problem because you may have voids. So there is a balance that needs to be met. And there's a reason why out of those studies, 5 seem to be literally somewhere in the middle between being for or against. Actually maybe 3 of those studies seem to be sort of ambivalent. So out of all the things I've discussed, I think sealer has, choice of sealer is the least likely to influence the outcome of your endodontics. So my little summary is don't use cotton pellets. Extrusion of gutter poker is bad. If you use fancy techniques to obturate, be careful not to extrude. And no sealer is proven to be definitely better. And sealer puff is generally bad, and you shouldn't aim to get one, but it's not the end of the world if you have a sealer puff. So if you have any questions, feel free to ask. I'm very easy to contact. I am on Instagram and Facebook. And you could, if you want to see my slides and my other slides, I have a lot of educational posts, not limited to just this little topic. And I think most people find it interesting. And if you don't even find the science of endodontics interesting, usually 1 in 3 posts, although it doesn't sound like it's possible, I make endodontic jokes. And some people seem to love them more than the actual science itself. And otherwise, you can, if you're a bit of a dork and you like research, you can also follow my professional profiles too. Again, thanks, Alex and Dan. And are there any questions?
Thank you so much. I think you talk about dorks. I think, every dentist, there's an element of dorks in all of us. So we enjoy that kind of content. Thank you so much. There's a few questions that have come through. I've got a few questions that we'll elaborate on. There's a few things that I know that, like you said, the topic's quite huge. There's a lot to cover. There's a lot of golden nuggets there in terms of, a lot of issues that a lot of us has. How do we go from a size 10 to a size 15 file, curved canals, heat treated, a lot of things that a lot of us kind of maybe were taught maybe some concepts in initial undergrad school, and then we just kind of picked up our way and seen things and done things, but not really understood why in private practice as we've been exposed to a certain system. Funnily enough, I did ask people, are they using Pro Tape or TF? And it was like a 10-to-1. So dent supply is definitely
you've probably seen my surveys on DPR, and pretty much 90% of people use dent supply. Good
marketing. I'm not sure what it is. but it's interesting in itself, and just maybe lends to what systems that people need the most amount of help with, and how to get the best results out of that system in general practice. And obviously, definitely an interesting point in kind of what we all get exposed to and what we learn and how we get the most out of it. But before I do, we'll get into the questions soon, and we'll kind of have a bit of a discussion. Have a little moment to relax.
No, is it Harry's turn?
Yeah, we'll get Harry.
Oh, yeah, okay, cool. All right, cool.
We'll get a change of the share screens, and we'll get that going.
Okay, so
we're really excited with Mordent. We're able to create these webinars for you. There's a lot of excitement. There's a lot of packaging and a lot of programs and things that we're looking forward to in the future. So keep your eyes out. We've got a few really cool projects. So there's going to be a few prizes and awards coming out soon. So get your friends involved in the study club. And without further ado, we'll get Harry in, and he'll talk a little bit about M-Guides. Daniel and I have talked about Mordent and implant planning and how to start your journey. And really a strong aspect of what they do is really the 3D, the scans, the digital, and getting into a planning phase so that you can pick the right cases and do them well. So Harry's going to elaborate a little bit more about that, and then we'll come back in a moment.
Okay, thanks very much. I'm just sharing my screen. How does that look?
That's great.
Up. Is my screen up, guys?
Yep, that's working well. Thank you.
Okay, thanks. All right, so tonight, thanks very much for giving me this opportunity. I'd like to talk to you about M-Guide and using digital integration today to give us that ability to, I guess, release the power of digital integration and use it together with guided surgery. Guided surgery has been around for a very long time. And guided surgery is based on the principle that, or true guided surgery anyway, is that you take a CT and we use the CT to give us the qualities of the bone and the relative volume of the bone that's present. And then we take a digital impression of some sort, whether it's a physical impression, which we later digitize, or an intraoral scan of that tissue and overlay it. The reason we do that is because CTs get fluorescence of the bone and of the teeth, and they're not accurate enough for us to identify surface. So we take physical impression and we overlay that over the CT, and that gives us a very accurate way of designing our guide and working out where it fit and how it'll seat. But we design our implant position on the CT and we overlay the two and join them together, and that gives us the guide. The M-Guide is a newcomer, a relatively newcomer to the implant market. It's the most recent of the guides, and why didn't have a very good reputation because accuracy wasn't as good as it could be. M-Guide being a much later comer, we looked at the deficiencies in the guide concepts, and we brought new concepts. So the M-Guide is an open guide design that lets you do flapped or flapless surgery. It's particularly important that it has a precision positioning feature that sets it apart quite distinctly from all other guides. It uses no drill keys. It directly into the guide and place the implant for guide. And because of its design, you have much shorter drills, so you've got much better access. And that means if you get into molar areas, it's relatively easy to position it. So just to talk about the precision positioning of the guide, if you have a look at a guide, we design we actually design exactly teeth and what teeth.
Harry, sorry, we're just having some audio issues on the back end from your end.
Okay.
We can quickly do? Sorry for interrupting. Sorry, everyone.
No, that's okay. Let me just minimize this and have a quick look. Can you hear me talking?
You seem to be very clear when every time Alex is on, you're clear, and every time he's off, you're unclear. You're like his lucky charm.
I'm happy to stay on. Maybe if I move my mouth,
it could be something to do with that, because we seem to have very good bandwidth at this end.
Okay, we'll keep going until we'll see how we go.
Okay, let me just pull this up and just give me a yell if you got a problem, okay?
Sounds good.
Here we go, got it. Okay, so because we can position our implants our guide very accurately on the teeth, we've got a huge start in the accuracy of the guide. If you can imagine that all other guides sit over the whole dental arch, then their potential for inaccuracy is huge. Whereas we can pick the positions that we want to sit on, and we can get a much more predictable outcome. Now, the other really interesting thing about the guides is that our guide is keyless. You don't have a drill key for each different size.
And all the brands.
I missed that. The beauty is that the drills actually drill directly through the guide as we do that, as opposed to most other brands that have a drill key. Now, saying that we've already got the guide and we've got a very good technique to use it, what we really also have is the ability to deliver a restoratively driven solution. And that's because when we use exocad, we can take our photos, our intraoral scans, and our CT and overlay them over the top. And we do all of our restoration based in the one formula. So we don't just build it on a model and then try and relate it to the rest of the arch or to the person. All our biometrics are all built into the design from the outset. You may recognise this gentleman, the subject of my talk, as Kane, who presented to you a couple of weeks ago, or maybe even last week. So having said that, we can then choose smile design elements, and we can build them with our photos all into the one CAD development. And as we do that and work out exactly the design that we want, we can then export that into MGuide and position our implants with MGuide, having taken all our restorative inputs before we do it. So we, in fact, have the ability to walk through our case before we actually restore it. So we've got a very good predictor of what we're going to look like long before we go to position our implant. It means that digital dentistry is giving us the walkthrough that you see in architecture that we always dreamed of but could never quite have. And of course, we can build our articulation and do virtual articulation of that case. So Smile Guide now is no longer just a sales pitch. We build that in and integrate it with everything we do so that we're getting a pretty good outcome. So if you think about it, the CT that we take now is the center of everything we do. The CT is a scaffold for our design. We overlay our intraoral scan over that. We overlay our photography over that, and any functional measurements we have, we can plow those in as well, and we can design everything on CAD long before we go to do our implant position. We then export that into MGuide. We do our implant positioning and we export that back from MGuide back into exocad, and we're ready to start restoring. It means that we can build temporaries, we can restore immediately after insertion in cases where there's good enough support. We've got a whole new ballpark. It also means that all of your cases, whether you're doing them yourself or whether you're referring them to a specialist or someone to help you do the surgery if you're not totally comfortable with doing it yourself. You can, everybody, all of that team still works on MGuide with our MGuide team. So you plan your cases together with the person you're referring to, if you're going to refer, or you do them yourself. And even if you are not au fait with digital and with modern CAD CAM, our team is there to help you do that. We can digitize all of your information. If you can take a CT and take a physical impression, our team can convert all of that information and take any photographs that you can send and add them into the CAD design, and you're ready to go. So we can project very, very accurate outcomes long before you make the move to surgery. And we give those to you in a form that you can present to your patients. You can work online, digitally, directly together with us, together with a surgical collaborator if you're referring for surgery, and also with your lab if you've got a lab. We also have a very strong lab department who can also provide the lab and the lab for you, which is, very, very important if you think that we can provide everything you need from beginning to end. And I think we're the only implant company in Australia that can do that. So the other thing I want to mention is if you are collaborating with a third party, if you're referring to somebody else, it's important to know that maxillofacial surgeons today can access the prosthesis list when they do surgery in hospital. And when you're doing that, surgical guides and implants are included in the prosthesis list. That means the patients don't pay for them. So that brings the cost of your surgery down dramatically and the cost of your whole case down dramatically. So when you're choosing a referral partner, it's worth considering that. Okay, and just to mention our MGuide and MCAD teams who are there to help you. Our MGuide team is there to help you work out exactly where to put your implants. Our CAD team is there to take all of that data, the scans, the CTs, and the photography, and built it into one design, and then advise the MGuide team once they've done it if their prosthetic solution is workable. So that means we never build a solution that isn't workable. Everything is done in an integrated fashion from beginning to end, and you, the surgeon, or you, the referring dentist, together with the surgeon that you refer to, all work together collaboratively to agree on the outcome. And also, we've got training for those of you who want to build that. Definitely come with us, and we can bring you to that standard. We can show you how to use the CAD. We can start you slowly with a single case and build up to very, very complex cases. Finally, I'd just like to mention our website, which I didn't have time to add to the slides. If you go to moredent.com.au or dentalimplantologyacademy.com.au, there are links to MGuide and surgical processes that you can see. If you look at our COVID link, you can see all of our recent webinars, and amongst those are very interesting examples from maxillofacial surgeons and other dentists regarding how to apply technology in today's age. Thanks very much.
All right. Thank you so much, Harry. We'll get William on board and we'll go straight into Q&A.
I'm just going to turn off my slide sharing. Hold on.
Fantastic. Thank you.
There we go.
We'll look at doing more presentations, maybe looking at how people can get into implants as well, and someone who's been there and what that's involved. Now, Will, how are you going? You're still with us? No patients tomorrow at the university, or?
We're back in uni in 2 weeks' time. The uni is very cautious. Rather than throwing us out into the I don't know.
Yeah. We'll see where we are. We might be closed back again in 2 weeks. So I feel like endodontics seems to be busy nowadays, especially with a lot of cases, especially I've heard in private practice, getting built up over the time period and then trying to finish them off and get people out of pain and stable. And, I think we talked about this before, endodontics, in a way, you're dealing with infections, and that's part of the beauty of that profession.
Yeah, like there's always going to be too much sugar, too many toothaches, uh, and too many casts.
too many of my composites that are leaking, or one or the other, right? So I will go straight into the questions. There's a few interesting ones in regards to more complex cases and how to circumnavigate them. I think something that we talked personally was also kind of anesthesia and how you could go about that. I think let's just touch on that very briefly.
Okay.
I know that's a whole topic in itself.
Yeah, so I've got some slides that I can get up. They're also on my Instagram. It might take a bit of looking up because they're from quite a while ago.
I think what's maybe more principles? What's a common mistake? Is it a lack of volume of anesthesia? Is it a lack of a combination of anesthetic techniques for lower molars, doing a block and infiltration, buccal and lingual, and knowing your anatomy a little bit better? Where do you see most common mistakes lie in that area? And then we'll go into more of what the presentation.
Okay. So I think the first step is not to immediately resort to putting more anesthetic in exactly the same location, because there's two problems. The first is if you missed your target the first time, you'll probably miss it the second time. And the other point would be if you're not deep enough the first time, you're probably not deep enough the second time. So an example is if you're doing an infiltration, and the first infiltration, you tend to be nice to your patient and be like barely under the mucosa, which then means the anesthetic is lining up with the root apex. So if you're going to go in again in that same spot, at least even if the tooth's not numb, the mucosa is numb, and hence your needle should be deeper. The next point is, say, if you're giving a block, if you've tried an inferior dental block, the next thing you might want to try is the Gao gates, because if there's any variation in anatomy, by doing the same block again, you're probably still going to miss the nerve again. So from that point of view, you should probably, again, think about an alternative anesthesia technique. And
I think sometimes a good combination, and for those who are maybe less experienced with Gao gates, is maybe doing your block higher.
Yeah, so pretty much, aim higher. If not, look up the Gao gates. Once you learn it, you'll be like, oh, I should do this a lot more. I'm not saying the Gao gates would always give complete anesthesia. And I think there's a paper that says if you've got a hot pulp, 70% of the time you'll need a supplemental injection of some sort. So just be prepared to know that. So don't just give one and then test the patient, I think, because if most of the time the patient's just going to lose confidence. If you've 70% of the time your patient will lose confidence, at least give that supplemental and then check it out. So an example would be if I'm working on a lower molar, I would give a inferior dental block, a Gao gates, and then a buccal infiltration as my first series of local anesthesia techniques. And then I would even consider a lingual if for whatever reason those don't work, and then I'll go back and give those other ones again. The other problem about giving too much anesthetic in the same location at once is that if you imagine there's a nerve and there's a little ball of local anesthetic here, if you add more, it will just be pushed. It won't even go towards the nerve anymore because the excess fluid is being pushed away. The site's already saturated. So you need to give, if you're going to give it time to work, you might as well be giving a different technique where there is time and space for it to diffuse into the tissues. I hope that makes sense.
No, absolutely. I think that's a good point. And we could go on with this for a long time, but we'll go into a few questions related to the presentation. There was a question related to, ledge canals and preventing perforations, but I'll take a step back and maybe what we could do is elaborate, when we're seeing periapical radiographs, which is, 99% of the time what we work with, where should we be seeing, or what kind of point should be like, okay, well, this is going to be a complex case. Perhaps there's a complex anatomy. Perhaps we should be taking a shift radiograph, or sometimes maybe referring for a CBCT of that area. What should we be picking up on radiographs that should give us an idea? Okay, well, this is going to be a case where potentially we may perforate, potentially we may ledge. What are key pointers there? So
if we just work, say, coronally to the apex, the first step, if you look at the crown, as a side note, I would almost always recommend you take for posterior as a butt wing before you start. it gives you an idea of the depth from the occlusal surface to the pulp. So you know how far you need to drill. If there's been occlusal wear, then you'll get to the pulp sooner because the occlusal surface has worn down. So that means you don't want to drill as deep as you would in most cases. But also, the bite wing is good because it'll give you an idea as to restorability. And let's say there's slight angulations in the tooth, because if the patient has a crown or very large composite or amalgam or something, sometimes the restoration is made to look like it matches the rest of the arch. But in actual fact, the roots may be going this way and the crown's going this way. And if you drill down this way, the root's going that way, you're going to perf. And then it's actually quite funny sometimes when I get a referral and it says, let's say, I've got to word this right. I couldn't find. Okay, I'll do. Actually, the one that I find funniest is I couldn't find the distal buccal canal in an upper molar, and then I go and actually that's the canal they found. Right. It was the mesiobuccal they didn't find.
Yeah.
And they've just been drilling further and further distally, and it's like, okay. But I can understand, like the thought would be like, well, you stick your file and it feels as though your file is in the most mesial point. But if you forget the fact that your file is possibly twisting as it goes into the axis, it could be going quite in some other direction. So the first step would just be judge the occlusal, the shape of the crown in relation to the neighboring teeth. And then you got to be able to see the pulp. If you can't see the pulp, you have to really ask yourself, is it worth it? Because you don't want to be telling the patient, I'll get you out of pain, and then after 90 minutes of drilling around, you still haven't found actual canals. Like there is almost no way you'll actually get them out of any pain, aside from the fact you gave them local anesthetic. You really just wasted their time. You could have just given them local anesthetic and not even drilled into the tooth. That would have been the nicer thing to do. If you can't see the canals, you've really got to ask yourself, is it worth getting into? The next thing is then the angulation of the tooth, again, the root of the whole tooth.
Yeah, those curvatures.
And then the curvatures, because it's quite easy unfortunately, when you're measuring obtuse angles, it's very hard to measure the angulation. Like if I was to say to you right now, draw 30 degrees, literally isn't a 30-degree acute angle. You could draw that pretty easily. But if I said to you, draw 150 degrees.
Yeah.
I challenge most of you to be able to draw it as accurately. So there's ways, like now with digital software, you should really be able to measure the angulation. And if you don't, if you're using plain films or you're looking at an OPG for whatever reason, or your radiology software doesn't actually let you measure angles, just get an app on your phone that measures angles. Like that most of them are free. They might tell you, say, 150 degrees as opposed to a 30 degree. So like, as we call it a 30-degree angle when it's 150. But if you can do that, it can probably save you a lot of heartache, because something that doesn't look that curved can be more curved than you think. And then you're almost likely guaranteed to ledge unless you've got the full gamut of gear and know what you're doing and know what to look for. Okay.
I think that's a good step. I mean, for, again, more complex cases, having that bite wing, having that PA, like you said, estimating the working length through your measurement tools to the pulp chamber, looking at, like you said, root morphology, and getting an idea. And if you're, more than 30 degrees angled, once again, having another, consideration, do you have the right equipment? And, how helpful is this going to be? Is this going to be worth your time as much as it is for the patient as well, and the stress that goes with it? So I think that's really good points. Is there, common cases, like for me, sometimes lower incisors, they're sometimes the most stressful. Are there common, or MB2s are obviously a very common area as well. Are there other areas that people see, okay, well, how can I get a better idea of whether there are kind of extra anatomy? And
okay. That's
I'm sure there's a lot of things that we're missing that we don't even realize we are sometimes.
Okay, so there's a so basically the question is, how do you know if you've missed anatomy? Is that the question?
Yeah,
Okay. Well, like aside from, yeah, so obviously you take your PAs. A tube shift is a very useful way to start. Like you can pretty much like yeah, you can identify a whole lot more if you've got a tube shift, because like the average person, when they take a PA, they go into almost bite wing mode, and the image is like, if there's two roots, I can almost guarantee almost all of you, when you take a PA, it's like this. And you go, is there one or two? I don't know. A tube shift does help, but the issue then becomes like, where are they placed? Like, you have no idea. It's like it takes a bit of thinking to figure out whether it's like buccal, lingual, and that, even if you see the number of roots, that doesn't actually clarify, say, the number of canals. So a common one would be, say, your lower molar. There might be so-called the mid-mesial canal. So you have to like do a little troughing, and then there's a little canal that joins between the two. That's a commonly missed one. But if you want to start somewhere, probably the place to start, there's a paper by Krasner. I'm pretty sure it's Krasner. And it's got a lot of nice pictures, which are very cartoony, but it gives you some fundamental concepts as to where to find the canals. As a general rule, if you've got something that should be, I don't know, an oval shaped, and you've only found one canal here, then you can almost guarantee that there's a canal over there. Like, that's just like, that's a very big generalization, but the Krasner paper is pretty much the place to start. Like, it doesn't keep the paper, unfortunately, doesn't put into consideration that if you're doing a root canal, the tooth's probably had caries for a long time, which then means it's had tertiary dentine placed for a long time, which means some of these ideal guidelines that we've been taught sometimes almost go out the window, because sometimes due to tertiary dentine, the canals are no longer literally in symmetrical positions. One's actually sort of submerged a bit. Yeah.
Well, I mean, that actually comes into a good point. So how do you prevent, I mean, perforations? I mean, obviously, I think magnification is probably a key aspect here. For those that don't have a microscope, what would you be suggesting? Greater than 4 times magnification if you're trying to start, battling some of these calcified canals. And where do you draw the line and say, okay, enough's enough. My back's hurting too much, or things like that. And where do I get the script pad out? Or
I think the thing that a lot of people forget is there's probably no point having loops if you don't have a light, little torch, because if you're looking into darkness and you magnify that by 4, then it's still darkness. So like I even advocate using a cheapo headlight from, I don't know, some hardware store or camping store, camping store. If you're not going to invest in the nicer, more expensive lights, and if you do get a light, try to make sure it's aimed roughly as close as possible to between your eyes, because having a light on your forehead, it's not as useful, like, for obvious shadow reasons. So to prevent perforation, little tips would be to get a good idea as where the long axis of the tooth should be. So that's why the PA and the bite wing is quite useful. And if you've pre-measured your drills, and let's say on your bite wing it's, I don't know, 7 millimeters to hit the pulp. If you drilled 7 millimeters and you haven't found the pulp, just stop and take a PA, because either you're just about to reach, and they'll be like, yes, I'm spot on, keep going, or you are pretty much about to perforate. So in some, almost like
you're either about to open a present or about to get
but you shouldn't. Yeah. So, but if you follow that depth, you shouldn't actually. You'd be very unlikely. Like, if your tooth is here and 7 millimeters is the pulp, if you go 7 millimeters this way, you still really shouldn't hit the external surface. It's when you just keep on going out of stubbornness that you'll do that. So at least it gives you a chance to stop and correct and re-angle it. So that's probably the first point. The next thing is, although not everyone suggests this, it's sometimes handy not to do single tooth isolation, because if you can see multiple teeth in the arch, you can actually see more of the crown form. And if you can see more of the crown form, you have a better idea as long axis of the tooth. Because some people, when they put rubber dam on, the rubber dam is pretty much pushing quite. you can't see the whole crown basically. And if you can't see the whole crown, you have far less of an idea. So some sort of cuff technique, or I don't know what's it called. I always get confused between
like multiple tooth isolation.
Some sort of multiple tooth isolation. Like obviously you don't want your rubber dam flopping around and irrigant going up and down, your tongue poking through. Like you still need to seal it down well. But if you can see pretty much the whole crown of the tooth, it'll give you a good idea. Of course, be careful if you've got like a prosthetic crown on top.
And things that are changing.
And the other thing is if you clamp a different tooth, the tooth you're working on, if you take a PA halfway through your prep, you'll actually see where your drill, where your path is compared to the canal. If your clamp is on the tooth, you're less likely to see where you're going.
Yeah,
so if you think it's a high risk perforation case, then I would heavily suggest clamping a different tooth. If it's an everyday case, I don't know, who cares? So you just clamp that tooth for all you want. But if you think you're definitely not going to miss, but if you're pretty sure you have a high risk of missing, well, obviously the referral pad's always there. But if for whatever reason you feel game, then clamp a different tooth and then take a PA once you've reached, say, whatever arbitrary depth you think is the position of the pulp.
I think that's a really interesting point. And part of that, I think one tip is plastic clamps as well. They can be really handy in these kind of cases where, you don't want the clamp itself interrupting your x-rays. Another question in regards to, I guess, more complex anatomy and things like that, where perhaps it was initially treated and, it's become reinfected after a year, the patient never went through kind of having a chemo mechanically prepared. And for whatever reason, the previous dentist or yourself, whoever you want to blame at the time, has ledged the canal. Is there tips on how to kind of re-navigate? And, obviously, is it a very tactile feel and using smaller files and patience is?
So if there's a ledge, the first step would be to identify the position of a ledge, because otherwise, it's easy to tell someone pre-curve a file and keep poking around until you find it, but you're literally just poking in the dark. So the first step would be to know the position of the ledge. Ideally, you'd have like a cone beam so you can actually see where the canal curves. Because if you have a PA, it's one thing saying, the canal curves this way, but then you might take the cone beam. It's like, well, actually, it's going that way. Like it's a combination of both. So ideally, you'd have something three-dimensional to judge where the ledge is at its most likely position.
I think that ties into, S-curves are notoriously dangerous for this kind of situation and not having the right kind of files.
Yes.
To navigate.
So once you know where the position of the ledge is, the next step is to try to actually so basically be able to tactile, to feel where it is with your hand files. If you can get to it, the next step would be, so those heat treated rotary files, you can pre-curve them, and obviously if you can see what you're doing and feel what you're doing, you can actually aim them towards the ledge, and then you can get the rotary going once it's past the ledge, and once you prepare past that, you can get further through. But having said that, if you can't feel and see what you're doing or know what you're doing, and you're just sticking a very large rotary file to the position of the ledge, you're just going to create a bigger ledge. So you really have to aim exactly where that opening is. Otherwise, you'll do more harm than good. The next note is, if you're willing to, if you're someone who treats a lot of ledges, the next step is you can buy rotary files so most rotary files, obviously, they go to a tip. You can actually get rotary files that actually are intentionally curved one way. So you can get an example is the Tommy Dent guys sell this file that's angled a particular direction. Or if you use the FKG shaping file, it's got this little S shape. So if you know what you're doing and there's a lot more into it, you can actually get the rotary file that will just, based upon the setting, will actually try to poke around until it finally finds it and get through. Again,
Yeah, a preformed shape to the anatomy that's already present. Obviously, you know, we're talking about very experienced people here. But I mean, it's interesting. I mean, it's really good to just know that these options are available for people, and to know what kind of tools, you know, someone who they may be referring to does have in their armamentary. That kind of actually fits into my point. I know it's something that comes up in private practice quite a lot, especially in general practice, is how often can you reuse heat treated and not? Now, I know what the you know, the textbook answer is, but is there, where are the concerns, and where is there, I guess, options and possibilities of doing things that's going to be still kind of, I guess, efficacious and things like that?
Yeah, okay. So we'll just start off with I suppose the concerns, and then we'll get on to, if you were to do it, what you could do. So if you were to reuse rotary files, the first point would be that if one of them breaks in a canal, and you just so happen to break it in the wrong patient, and you'll never break a file in the right patient. If you break it in the wrong patient, and for whatever reason they wanted to sue you, even if things healed perfectly, what happens if it's some person who just wants metal out of their mouth and whatever reason? Because you get those patients. Yeah. If for whatever reason your records had to be accessed and it shows that you were reusing files, sometimes it's not necessarily what is legally wrong or what is medically wrong. Sometimes it's what is the worst thing that could be said about what you did on the front page of the newspaper. And if it was to say that, I don't know, Dr. X is reusing medical instruments and and left them in a patient, it's like, there is no way you can word it so it sounds okay. Like, it pretty much would end your practice. Even if patient's fine, you paid for either removal of the file or whatever, if it goes front page and everyone in your community hears that you broke a file in that patient and it was reused, that could end your practice.
Is that very different to, I mean, it's still sterilized and it's, you know, like we have many equipment, and this is, I guess, more of a discussion and just trying to figure out. So, I mean, medical equipment is sterilized and time. Is it?
Yeah. Well, just
where is the difference here?
So, like, although the difference would be that the good thing about endodontics is if the file breaks, it's actually entombed in the tooth. It's not like a pair of scissors sitting up against someone's spleen.
Yeah.
And then, you know, so that's a good thing about endodontics. So the sad thing about endodontics is that patients don't know endodontics. So they'll if they hear that something's left in their body, they'll just associate it to anything they've heard on the news about, you know, doctors leaving instruments in someone's body and causing persistent problems until, you know, the patient had investigated. So, so that's just that's the concern. And even though, so the other thing is, even though we can sterilize the files, as in we put them through the autoclave, or we might have some sort of, I don't know, the Parashos protocol. The other thing is that, like, it's still, like, effectively, almost all the rotary files, if not all of them, say that they're single use only. So you are breaking the law in Australia, because the files do say single use only. And if you're not following what is recommended by the Australian Therapeutic Guidelines, if you do something beyond its intended use, then I don't know if your insurer can actually defend you. I don't know, because, like, you know, you're breaking the law. Like, if it's,
I think this is important information for everyone to at least be aware of, because a lot of people aren't.
Yeah, so it's one thing for someone to say that it's sterile, it's fine to use, but, like, what happens if someone says, well, can I autoclave my Toffel-Meyer matrix band? Like, just imagine if someone did that. Like, so that's the issue. Now, having said that, now, if you were to do it, and you're very careful, the next issue then becomes, for every case, the question is, like, you have to have really good tracking if you want to minimize the risk of your files fracturing, because now I can't remember. I don't know if it was Alex Moll or Parashos. Like, one of them had this paper where they just had all these different practitioners keeping a record. This was back in the early days when everyone was reusing rotary files, because the whole so when Profile and ProTaper Universal came out, they didn't actually say on the packaging single use only, and that was at the time that was like, everyone was just reusing the hell out of them. And there was actually the study where they tracked all these endodontists, and it wasn't actually the number of, there was no statistical significance clinically on how often people would break files. It wasn't like 6 cases, bam, seventh case, it would break.
Yeah.
It wasn't, unfortunately, not as arbitrary as that. It was, and it wasn't experience. So it's not saying that rotary files break randomly. It's just that
it's very difficult to track. Is that?
Yeah, there's
obviously each case is not the same case.
Yeah, so every case is different. So unfortunately, you can't say arbitrarily. Unfortunately, you can't arbitrarily say 6 cases, bam, break.
Yeah.
So because every case is different, and then let's say you do an easy case, and then you do a 4-canaled molar.
Yeah, of course,
Then is that technically 2 cases, or do you call that 5? So so that's one of the issues.
Well, I think that's, I mean, I think it's a complex issue, but as we all know, it happens very commonly. So I think it's just something for people to be aware of and understand the concerns and the cautious.
Yeah. So my tips would be, if you're going to be a cheap ass and you really, really want to reuse your files, the first would be, do not use EDTHLs, because that's just going to break your files twice as much anyway. The next thing is, you may want to look into reciprocation. Now, it's another talk in itself on how to use reciprocation. And if you're going to do it, you need to train yourself on how to use it. And there's also multiple motors that don't work on every single file. As in, it's just just doesn't. You need to talk to people who use reciprocation to explain it to you, because if you remember, when you use hand files, you do the balanced force technique, so you can get your K file to length. As opposed to, if you've got a K file and just twisted the hell out of it, it'll break. So so reciprocation is based on the balanced force technique. So if it starts to bind, the rotary file will always unwind a little bit. So if you really want to get more mileage out of your rotary files, look into reciprocation. You don't need to buy a so-called reciprocation system. Whatever rotary files you're using now, you can literally, if you know what to buy, you can buy a motor that will actually work on your rotary file.
Okay. Well, I mean, that's a good tip. Maybe what we can do is end on there. Which system would you, for those that use ProTaper, which seems to be the most, what is a reciprocation system?
No. So what I'm getting at is, let's say you actually already use ProTaper. So officially, that's not a reciprocation system. That is a rotation system.
Yeah.
If you stuck that into either a Tommy Dent 8-teeth motor that does reciprocation, or you stuck that into the Super and Endo Elements E-motion thing and set it onto Twisted Files adaptive motion, that would be reciprocation movement. Talk to the reps first to make sure it's going to work. Because if you just stuck your ProTaper into a Wave 1 Gold reciprocation motor, it'll go the other way and it actually will not cut. So before you invest in a motor, just make sure it will work. And you might have to ask a few people just to confirm.
Well,
but strictly speaking,
I think that kind of summarizes and ends the presentation quite well. Know the equipment that you're using and why you're using it, and where exactly it fits. I just want to thank you so much again.
And try it on extracted teeth before you try it on a patient. It'll feel completely different. So don't try a new technique unless you've tried it on extracted teeth.
100%. That works for uptrading systems, chemomechanical.
Yeah.
Get a feel. Everything is tactile, especially in endodontics. So thank you so much again. We've had great entertainment and all the presentation worksheets up as well for everyone. So everyone have a good night. We'll touch base next week on Tuesday, same time. We've got Dr. Tiv coming back with communication. How do we get patients to value what we want to do and keeping their teeth and all the rest of it. So thank you so much, Dr. Will, and take it easy, everyone.
All right. Yep. Cheers. Thank you.
this is to end in fire, then we shall all burn together. Watch the flames climb high into the night, calling out, Father, oh, stand by and we will watch the flames burn over and on the mountainside. And if we should die tonight, we should all die together. Raise a glass of wine for the last time, calling out, Father, oh, prepare as we will watch the flames burn over and on the mountainside. Desolation comes upon the sky. Now I see fire inside the mountain. I see fire burning the trees. I see fire hollow and soul. I see fire burning the breeze. I hope that you remember me. Surely I'll do the same. Confined in mountain holes, we got too close to the flame. Calling out, Father, oh, hold fast and we will watch the flames burn over and on the mountainside. Desolation comes upon the sky. Now I see fire inside the mountain. I see fire burning the trees. I see fire hollow and soul. I see fire burning the breeze. I hope that you remember me. this is to end in fire, then we shall all burn together. Watch the flames climb high into the night, calling out, Father, oh, stand by and we will watch the flames burn over on the mountainside. And if we should die tonight, we should all die together. Raise a glass of wine for the last time, calling out, Father, oh, prepare as we will watch the flames burn over on the mountainside. Desolation comes upon the sky. Now I see fire inside the mountain. I see fire burning the trees. And I see fire hollow and soul. I see fire blood in the breeze. And I hope that you remember me. Surely I'll do the same. Come finding mountain holes. We got too close to the flame. Calling out, Father, oh, hold fast and we will watch the flames burn over on the mountainside. Desolation comes upon the sky. Now I see fire